Oh, okay. Can you guys see me okay? Does it look like there's enough light? Is that better?
That's better.
Okay,
Yeah.
there we go. Perfect. Okay, well, I'm going to go ahead and get started. So, might as well. Well, thank you tonight for everybody that's joining us live, and for those that signed up, they will also get this sent to them in their emails. I'm going to introduce Kylie Baker. Kylie is our operations manager, and thank goodness for her. She'll make sure that you do get the recording, and she's really important as far as making sure that this whole program works properly. Kylie, also, will you explain kind of how we do it, as well as also explain what we have upcoming?
Yeah. So generally, in the beginning, we go through all the PowerPoint presentation, and we save the questions and answers for the end. That way, we can make sure that we get through the PowerPoint presentation in a timely manner. And then we always save, I don't know, anywhere between 15, 20 minutes or so at the end for questions and for Greg to answer as well. And then our next upcoming webinar is 2 weeks from today. It's September 24th. And the topic on that is going to be adrenal.
Great. Well,
so, yeah.
And we're also joined by our nurse, Paula. Paula is my right and my left hand. She helps me do all my consults, and she helps me investigate all different formulations, etc. So she's really important. She's our nurse, and she's been with me for, well, forever now, haven't you, Paula? Like
For a while, yes.
For a while now, yeah. Oh, quite a while. So, okay. Well, we'll get started. Maybe get my mouse to work. Okay, there we go. Can you see that slide, Kylie?
Yeah,
Okay,
looks
great.
good.
Okay, so here I'll give you my 30-second advertisement. For Fort Wayne Custom RX, we are a locally owned and operated pharmacy. We've been compounding for now over 15 years. We're into our 16th year, of which Paul has been with me close to, what, 12, 13 years of those?
Oh, yep.
Most of them, yeah. And our mantra is no two patients are alike. So we look for customized individual solutions, whether we're compounding things for babies like Riley butt powders, to things like for animals, like cats. We make ear medicine. We make an antithyroid medication for cats and dogs. And we make medications for the Fort Wayne City Zoo, as well as we make medications for 90-year-old patients. So we make all different ages, from infants to aging adults, from simple products to complex products that are that are considered sterile products. So we do all kinds of compounding. That's the bulk of our business. So this little 3-ring thing here just kind of shows you our philosophy of what we do. We obviously we do the compounding, and we are PCAB or ACHC accredited. And I probably don't tout this as much as I should. We were the first pharmacy north of Indianapolis in the state of Indiana that was ACHC accredited, which means we allow an outside agency to come in, look through all our records. They check our testing, they check our processes, and they accredit us. And there's very few compounding pharmacies. There's only about 3 or 4 now in the state of Indiana that are even accredited, and we're quite proud of it. We're going through our 3rd or 4th accreditation now. They come through every 3 years now, and just, they'll be in the next month or two. They come through every 3 years. So we're making sure that they can get through our records, and they'll check everything we do. And it takes a lot of work, and that's why we have somebody like Kylie, an operations manager. Why we have Paula. Paula's in charge of all of our quality control in our pharmacy. She makes, she does internal audits. And so there's a lot that goes into things that we do that a lot of other compounding pharmacies don't do. And that's just to make sure we're making good quality products that are consistent from time to time. But what we're going to talk about tonight is low dose naltrexone, which of course is going to fall into the compounding area there. But probably the other thing that's equally important is we do a lot of professional grade nutritional and herbal type products. We're really proud of that. We carry real quality companies. And with that, we do a lot of nutritional consulting. And part of that is we also do medication management. So if patients are on 12 different medications and they want to know what medications do what, which ones interact, how to take them, how to best take them, they want to look for nutritional deficiencies from those medications. We do have a service where we do that, where we do a full sit-down consultation. Paula does a lot of the hormonal consultations with women, and I do a lot of the nutritional medication counseling. And so, we think we offer something that's very unique in the Fort Wayne area, and it's very important for us. So a little bit about me. Aha, there we go. I'm trying to figure out how to do this better. I've been working in pharmacy since 1981. So I'm kind of an old guy on the block. I've been around, seen a lot of changes in pharmacy. Of that, probably about 10 to 15 years, I worked in hospitals. 10 to 15 years, I worked in the drug chains, and I was actually in middle management. And then finally, for the last 15 years, I've owned this pharmacy. So, and some of those things crossed over. I worked in the hospital while I was starting the pharmacy. So I've seen a lot of changes, and I know what I like to do in pharmacy, and I'm kind of stubborn in what I like to do, but I really believe in quality, and I believe in what we do. So tonight we're going to talk about low-dose naltrexone, and this is really something that really fits the niche of compounding, because we have found that patients that need low-dose naltrexone fall in a wide variety of different straits and different usages. And this is not some little overnight phenomena. This is actually, there's a whole organization, and they have an annual conference every single year where, in fact, I just got information. They're going to be doing another conference this fall, and they go through all the different science, and they have all the PhDs and all the research chemists and all the doctors that have been doing trials. And we're finding there's a plethora of information coming out, a lot of new information. And it's kind of exciting because it's kind of a little bit different. And we're going to find out what makes this so unique and special, and the wide varieties of patients it can kind of help. And we're real excited about it because we see a lot of different things within our own patients. So this first sentence up here is actually a statement that came off our Facebook site just about 2 weeks ago, I think it was. We had a patient that unsolicited to us, as found out we were going to be doing this talk, made a comment, says LDN has reduced the pain I have from my autoimmune disease drastically. I take 2.5 milligrams a daily, and we'll talk about what that means. That's enough to make a big difference for me. So, a small amount of medication can really help this person. The other person that was somebody that came in this spring, and she said, I've been taking low dose naltrexone. Now I'm completely off my narcotic pain medications the first time in years. So this is a real game changer for some people's health. So it's something we kind of sit up and take notice about. So a little bit of history about this. Low-dose naltrexone is actually a commercial product, and it comes as a tablet that's 50 milligrams. It also comes as an injection product. And a little bit of history to go back on that is it was first synthesized in 1963. So I can remember back in the 1980s, there was a product called Talwin, and the manufacturers put an extra ingredient in it that they called NX. So it was called Talwin NX. And that product was a product called naloxone. Naloxone and naltrexone are very, very chemically similar. Naloxone is actually an injectable product, and naltrexone is an oral tablet. But they work pretty much exactly the same way. And the reason why they put that naloxone in that product was people would take the Talwin tablets, and they would dissolve them in water and then put them in a needle and inject them. Now, that's pretty scary because Talwin is a painkiller, and they were using this kind of as a synthetic heroin, okay? But what the manufacturer, this is pretty common. I can remember I was working in Indianapolis back in the early 1980s, and people were coming in, we're getting scripts for this stuff, and they were selling on the street, and there was a real street value. It was really starting to become a problem. So the manufacturer put this naloxone, which is the IV form of naltrexone, in the product. And the reason why they did it was, as long as somebody swallowed the tablet, the IV naloxone did not work. But as soon as they dissolved the tablet in water and injected it, it became an injection. It didn't go through the liver directly. It actually blocked the effects of toluene. So in other words, it was a toluene blocker, or what we would call an opioid blocker. So when this drug was synthesized, they were looking for things to help people like for heroin addiction. And so in 1984, the FDA actually approved naltrexone orally as a product to aid in heroin addiction. In 1991, Yale did a giant study on alcoholism, and they found by using naltrexone that it was 2 times more successful than using a placebo tablet. In 1995, the FDA actually approved that drug then for alcoholism too. So we had 2 indications, one for heroin addiction and the other for alcoholism. In 2003, a injectable form, Vivitrol, was approved, and the Vivitrol was also used so that you give 1 injection that will last 4 weeks. So people didn't have to take it every single day. And then in 2005, they used naltrexone again in a combination product with bupropion, which is a drug used for depression. They used naltrexone in an 8 milligram dose. So again, a smaller dose than the 50 milligrams. But they used it because it curbed the potential for addiction to foods. So this drug has been around a while and it's been used for that. So how did we get used to it in compounding? And when did they get started using compounding? Well, again, in 1985, a doctor by the name of Dr. Bahari, who was a New York Harvard MD, was treating AIDS patients in New York City. And at that time, back in the 1980s, there were some different articles coming out in the science about these things called endorphins. And endorphins, you know, we kind of hear about it. It's that runner's high. You know, I like to run because I feel good running, and I don't run, I don't feel good, right? That's our own bodies and our own body's production of these chemicals. They get revved up. Well, these endorphins are what kind of give us these highs. And what they do is they actually attach to very similar receptors, and we'll talk about receptors in a minute, what a receptor is, but they work kind of like narcotics, okay? They kind of give you that euphoria effect, which is what heroin does, and morphine does, and some of the different narcotics to different degrees of euphoria, depending on how they bind to these different receptors. But we know that people that are addicted to running, they got to run every single day, right? If they don't run, they don't feel good. And so these endorphin levels. And so what they found was there was some theory about blocking these opioid receptors. And so naloxone and naltrexone were kind of looked at. Will they actually affect the immune system and affect these endorphin levels? And what we know is that AIDS patients, he found that in AIDS patients that 20% of them had 20% of the endorphin levels that a normal healthy human being would have. Okay, so they had low endorphin levels. And the thought was that these endorphin levels, again, affected the immune system. And the thing about HIV or AIDS is that your immune system is what gets attacked. And when your immune system decreases, you don't die of AIDS itself. You die of the infections that you get from AIDS. So if we could raise our own immune system, get our immune system to work better, then we could improve the treatment. And I can tell you, back in the 1980s, I've been in pharmacy a long time, there were not a lot of good HIV/AIDS medications. People were taking 18, 24 tablets a day of different things, trying to keep them healthy. And then if they got sick, we were giving them more antifungals, all kinds of drugs. And so it's not like today. I mean, HIV is a serious disease, or AIDS is a serious disease, but we have a lot better treatments than we did back in the 80s. So people were dying left and right. So anything we could do to help that. So what Bahari did was he had 2 groups of patients. He had a group of 16 patients that did not receive any of this naltrexone. And out of them, 5 of them got these infections. And then he had a group of 22 patients. And out of those 22 patients, he gave a 4.5 milligram dose of naltrexone. And how he came up with that was he kind of doing it off off a shoestring. He kind of said, well, I think it's about 10%, 5 to 10% of what a normal drug dose would be will have this different paradoxical effect. And so instead of actually instead of actually blocking the opioid receptor, it actually stimulated it. And we'll go through that in just a minute, how that happens. But what happened is basically these patients got better. And what he did over the next half a dozen years was he treated larger populations, and his populations tended to do best. They had some of the best success rates in the country. Well, so then we're kind of slow. We're not doing a whole lot on low-dose naltrexone. In 2004, when I opened my compounding pharmacy, we were doing a little bit, but not a lot. There wasn't a whole lot going on. And then in 2007, we got some really exciting research, and that was out of Penn State. And I'm going to talk about that here in the upcoming slides. There really was a seminal article about the immune system and low-dose naltrexone on Crohn's disease patients. 2009, there was an article in fibromyalgia from Stanford Medical School. They did a nice review on that, and that became published. And since then, really in the last decade, there's been over 1,000 articles on low-dose naltrexone. So the research is going crazy on this all of a sudden. So let's just talk about the mechanism of low-dose naltrexone. This comes from Dr. Chopra, who is part of Brown Medical School. They've done some research. He also is a big pain doctor there in this clinic. And so what do we know? Well, we know that low-dose naltrexone actually is an antagonist, and it blocks the opioid receptor for only a short period of time. So that big 50 milligram commercial product actually blocks the receptor for up to 24 hours. And if you give 100 milligrams, it does it up to 48 hours. And if you give 150 milligrams, it goes to 72 hours. Well, what we know is that as we block those receptors, the body has a tendency then to shut those receptors down, okay? And that's why people get some tolerance, why we have to keep giving more and more narcotics. It's that key of that drug fitting in that receptor like a lock and turning it that causes the effect. And if there's not enough locks and we're still giving drug, we have to start giving more drug to kind of overcome some of this effect. And so it's this positive feedback mechanism that increases the production of endogenous opioids. So what we found when we gave a little bit of low-dose naltrexone, a smaller dose, it would block the receptor, but only for a few hours. And as a result of it, the body made more receptors, okay? And that's what gives, it's the same concept that happens with runner's high. And so this endorphins or enkephalins are raised persistently. So we raise these, and when we say endorphins and enkephalins, these are our own actual natural opioid type products that our body makes. Is that, nod your head, Paul, if I'm making sense.
It makes sense.
Okay.
So.
So other things that it seems to do is it helps promote healing. It inhibits cell growth. So there's a lot of interesting talk about it in cancer therapies because it inhibits cell growth, and cancer, of course, is uncontrolled cell growth. It reduces inflammation by different mechanisms. You know, again, we talked a little bit about it works, it upregulates this thing called OGF, which is opioid growth factor, okay? And so again, if we give a large dose of naltrexone, it blocks this opioid growth factor and the opioid growth factor receptor, which is OGFR, it blocks that. And so then our body has to, it basically nullifies effect. But if we do it short term, then the body kind of responds and makes more of these. And so again, this is kind of how this works. It then works on a toll-like receptor, specifically toll-like receptor 4, the TLR4, which are little microglial cells. They're little nerve cells, basically. And it increases, it enhances the neural excitability, is what happens when TL4 is stimulated. So if we block that, then a lot of things, we've all heard about cytokine storms, right? We're all hearing about that in the news. It diminishes those cytokines. It also decreases this neural inflammation. Where this is going to come into play is things like serious pain disorders, where patients have this extreme pain that they shouldn't, and I'll have some slides on that to show you what I mean on that in a minute. So again, it works on this, modulates the T and B lymphocytes. So T1 dominance is in autoimmune disorders, and a T2 tends to be in an allergy. And what it does is it helps rebalance it. So we're finding that there's some potential for both patients that have autoimmune disorders and patients that have certain allergy type things. So we'll talk about that a little bit too. And this is, I don't need to go delve real deep into this, and I'm not going to. I don't know if I've got any doctors on here or not. I don't think most of you guys really want to know about this, but the important thing is it really helps balance some of these inflammatory pathways that our body does that aren't being affected any other way. So we give things like aspirin and ibuprofen and some of those type of drugs, but they work on different pathways than these. So these could be adjuncts or work alongside those type of medications. Okay, so if we look at a research study on patients that had done some low-dose naltrexone, just to find out kind of how people are doing this, we find that about 80% of them are female, and this is data that's come out of different different compounding pharmacies that have done low-dose naltrexone. We pulled our data together to see kind of what's going on, and we find that that dosage is ranges anywhere from 0.5 to 9 milligrams. So again, a much lower dose than 50 milligrams, hence the name low-dose naltrexone. And a lot of them are at 4.5 milligrams, and a lot of them are at 1.5. And before I go any further, I just want to say, I think they're in the low-dose naltrexone community, we all think of 1.5, 3, and 4.5. As I start talking through this talk, I will tell you it's highly specific and highly selective to the patient and to what we're trying to treat. A 4.5 milligram may not be the best dose for a Hashimoto's thyroiditis patient. In fact, it's probably an overdose. So we are getting smarter on how we use these. But in this study, when we started collecting data, again, over half the patients were taking 4.5 milligrams. If we look at the side effects on this, we find that the side effects compared to most medications is extremely low. So for example, 87% of the patients had no side effects. Well, there aren't too many vitamins I can sell that don't have side effects, you know, as nausea. So 87% is pretty good. The biggest problem we see is we do see some insomnia, and we do see this thing called vivid dreams. And it's because this is infecting those beta endorphins, those endorphins in the brain, and they tend to resolve after about 2 days on average. But 9% did, and we do see some headaches. And again, on average, they resolved within about 2 days. There are, of course, going to be some people, but very low amounts, that will not tolerate the drug. And I will tell you, my personal observations in the pharmacy is the vivid dreams are probably the biggest thing we see. So, just some different things. I'm going to flip through this really quick because I'm going to spend a lot of time on it. But there are a lot of different conditions that there's research and been used on. Hashimoto's thyroiditis is something that we see a lot of it used for here in Fort Wayne. Celiac disease, Crohn's disease, ulcerative colitis. Again, the seminal article that we're going to talk about is on celiac disease here in a moment, and Crohn's disease. Crohn's disease, not celiac disease. Vertigo, which is an immunological problem. Lyme's disease. We have a lot of Lyme's disease patients here in Fort Wayne. Breast cancer, colon cancer, lung cancer, lymphocytic leukemia, ovarian cancers. Again, the thought is because it affects some of the cell growth, it's being used as an adjunct. It's not necessarily a treatment, but it's being used as an adjunct. And there's some interesting research going on into cancer. And of course, these are all off-label uses. Pandas. Pandas is really interesting to me. This is a pediatric autoimmune neuropsychiatric disorders. And this is when people get infected by a strep infection and they become intolerant to everything. And they really have lots of different issues. They have learning disabilities, severe depression, almost a schizophrenia. It's really a severe, sad thing. Parkinson's, restless leg, anxiety, OCD, panic disorder, and of course with COVID going on, we're seeing lots of anxiety in our area. Depression, of course, is increasing. CFS. Ehlers-Danlos syndrome. We have a lot of Ehlers-Danlos syndromes and POTS patients in Fort Wayne, Indiana. And this is a connective tissue disease. And these people, they can't stand up without fainting. I mean, it's really a difficult thing to treat. Rheumatoid arthritis, scleroderma, sleep orders, PCOS. Okay. So if there's one article, if I've got any doctors on the line that I would read, it's this one here, the low dose naltrexone review of therapeutic utilization from Dartmouth Medical School, the pain department. And what they did was they reviewed 900 articles. They summarized the top 85 articles relating to LDN use for chronic pain conditions such as fibromyalgia, CRPS, neuropathies, joint pain, doing opioid tapers, mental health, ultra-low dose naltrexone, and on it went. And it's got some nice charts here. One of them is this chart, which I find very interesting and helpful. So can you see it when I circle the mouse like this?
Mm-hmm.
Okay,
yes.
Great. So the standard dose is 50 to 100 milligrams. And if you see what it does, it blocks the opioid receptor. This antagonism, it kind of reminds me of my younger brother. He was an antagonist to me. He would constantly be bothering me. So it's blocking that receptor. And so again, it's the goal is to block the alcohol and opioid receptors. So that's a 50 to 100 milligram dose. Look all the way down here. This is called ultra low dose. And the dose on this is 0.001 milligram. That's a lot. That's a tiny, tiny dose. So to put that in, that's also the same as 1 microgram, okay? And a baby aspirin has 80,000 micrograms. So it's 1/80,000th the strength of a baby aspirin. That's a tiny dose, okay? But look what it does here. It does the exact opposite. It actually potentiates the opioid effect. Instead of blocking it, it's actually improving it. And so I'm going to talk about that here in a minute, how that does that when I get to the article on it. But it works by totally a different way. It works on a different receptor. So the low dose, 1 to 5 milligrams, we like to use for things like fibromyalgia, multiple sclerosis, Crohn's disease, cancer, because it's working on the immune system. And that's because it's affecting that toll-like receptor 4. So it's working on that TL4, which I talked about earlier, that has more to do with that immune system, and it's working on the opioid growth factor. And then very low dose, so there's 4 different types of dosing here. VLN, we call it VLN, is greater than the 0.001 milligram or 1 microgram up to 1 milligram. And that's used to aid in detoxification. So again, it probably works kind of the same mechanism here, but at this stage, we can use it to add to methadone when we're trying to get the patient off methadone. So again, according to that article, a summary of clinical experience of low-dose naltrexone on multiple sclerosis per peer-reviewed literature. So it have charts like this, and it'll summarize all the different studies, and it may say, hey, there's no significant differences in this study. And in this study down here, it says exposure to low-dose naltrexone did not reduce the amount of disease-modifying therapy. So they're not all positive. However, in some of them, it may say majority reported improvements in quality of life and reduced fatigue. Well-treated treatments with insomnia and nightmares as adverse effects as a minority case. And so it'll tell you, again, it has some notes as to which kind and who did the study. This one here is the one on Crohn's disease. And again, we're going to talk about one of these studies here in a moment. But again, they classify and they talk about Crohn's disease, the difference, the experience of low-dose naltrexone. So speaking of, so here's the low-dose naltrexone. The first real big study came from Penn State. And what they did was they took 17 patients that had endoscopically, which means they confirmed that they had Crohn's disease. And they looked and they did a Crohn's disease activity index, and which is a survey. And they gave them 4.5 milligrams of low-dose naltrexone over the course of 16 weeks. 89% were responders with an average decrease of 70 points. And 67% of them achieved disease remission. And what they basically did here was 8 weeks before they gave them the low-dose naltrexone, they actually took them off their immune therapy. In this case, they were giving them infliximab. And they basically then started the low-dose naltrexone, gave it to them at bedtime for 12 weeks. And of all the patients, only one patient terminated the study. They had a flare-up. Before she actually even got to low-dose naltrexone, she had a flare when they tried to get them off the thing. And so they included that in the statistical analysis, even though the patient really didn't participate. And they also had a patient that actually had multiple sclerosis that actually had an improvement in some of her neurological symptoms. So that person got a 2-for-1 deal. You know, she got help in her Crohn's and she had help in her MS. So I am not an expert, but I guess on the left is a diseased part of the intestine, and on the right is somebody is the same patient that's had the low dose naltrexone and then has been in remission here for 6 years. Here's another patient. The patient on the LDN was added to a biological prescription. It doesn't say which one, and that patient went into remission for 7 years. Okay, so the other one that's really kind of a neat article to read, it comes out of Stanford, and this was a review of low-dose naltrexone's mechanism of action, effectiveness in treating chronic pain conditions, and what they found, they basically summarized and said low-dose naltrexone represents a promising new treatment for chronic pain conditions thought to involve the inflammatory process. So it goes through this article, talks about how it works as an anti-inflammatory. This one comes from Brown Medical School. This is a single-blind placebo-controlled study, okay? So in other words, some patients got placebo, some patients got the drug. 4.5 milligrams over 12 weeks demonstrated a 30% reduction in pain. And then again, the authors concluded on that one that LDN seemed to be seen as a highly effective, well-tolerated, inexpensive treatment for fibromyalgia. This one is a study from Brown also on complex regional pain syndrome. I did not know what that was until back probably about a decade ago when I started hearing about it. I didn't know such a thing existed. This is the extreme pain patient. This is a pain patient that's refractory to all pain medications. I'll show you some pictures that are a little kind of graphic, but in this case, in this paper, they actually, a pain doctor from Brown Medical School actually wrote up a case study on 2 patients that he used low-dose naltrexone on. And on those 2 patients, they became refractory to all existing treatment protocols, and they gave 4.5 milligrams over 2 months. The pain scores dropped from 9 to 10 down to a 5. Okay, so this is extreme pain. 9 to 10 is at the top of the pain scale, and they got it down to 5. They decreased decreased the patient's IV ketamine infusions. So ketamine is a strong pain medication. We compound some of that in a nasal spray, but an IV product is given in pain clinics, usually in a hospital setting. So these patients are really hurting badly. And the first patient was recovered, was able to bear full body weight, and stopped using a cane that they've been using for 6 years. The second got a complete remission. So let's see a couple of those pictures. So if you look on the right there, on A, you can see that this leg does not look very healthy, right? And so that person's in a lot of discomfort, and they were refractory. Can you imagine taking a narcotic and not getting relief for the pain on that? This is again case 1. You can see that the color of the leg has changed a lot. That there is some slight swelling. And then this is the 2 months of treatment with LDN. The patient was able to bear full body weight and walk without assistance. One year after LDN treatment, the patient still had persistent long-term trophic changes in the skin of both lower extremities. but he was walking. Here's case number 2. This patient had to have some surgical. As you can see, there's some structural issues here too. And this basically is like a spasm, I guess, is the best way to say it. They can't straighten that foot out by themselves. So they had to have some surgery on it. And again, using the LDN helped. And this patient's an Ehlers-Danlos. And these are the patients that their joint tissues are, I mean, they're the kind of people that we say are double jointed, okay, that shouldn't be. You know, when they're kids, they're the kids that can do the splits real easy. But as they become adults, they can't stand because they lose that ability of the muscles to hold them together. And they have problems keeping their blood pressure, and there's just all kinds of connective disorder issues there. Okay, so this one is on peripheral neuropathies. Okay, and this is in a diabetic patient. Again, another type of pain. Clinical case study of a 76-year-old male with a 30-year history of type 2 diabetes. So these are patients that have a long history of diabetes, 7-year history of neuropathic symptoms, and that's nerve pain, and that can be burning and numbness, and it's very hard to treat. Again, they used a scale, and they dropped from 90% down to 5%, and the Likert pain scale dropped from 8 out of 11 to a 1. And again, the author concludes the LDN seen as a highly effective means of treating peripheral neuropathies. This one is a joint spinal pain, and I'm going to move right along here, so I have plenty of times for questions here. But this is a clinical case study of a 35-year-old male with nonspecific left-sided chronic lower back pain. Again, different questionnaires. The MODQ is a modified Oswestri's disability questionnaire that's used to validate pain. And again, the patient got effect. And I am not a radiologist. I put these pictures on here for my doctors who can see. I can't tell you one way or the other, but apparently he improved. Now here's the one chart that I do understand. So this is worth noting here. It takes time for low-dose naltrexone to work. So in this patient, they were kind of coming along, and their scores pretty much were staying. They were dropping, but it took a couple weeks for it to start dropping. The first 2 weeks didn't get much effect, but all of a sudden, about week 4, there's some pretty significant effect. As you get about 6 weeks out, there's a lot of effect. Well, what's interesting on this is the patient stopped after 6 weeks of using the drug, and look, they maintain that for up to 6 months. So I think that's really fascinating, because that tells me that there's something healing or therapeutic that kind of happened there. Sarcoidosis is a disorder where there's these inflammatory cells that swell. They usually affect the lungs, and they can cause fatality. They can affect the lungs, they get it on the lymph, but they can also get in the eyes, the skin, and the heart, and other issues, other areas, other organs. And so this was pulmonary, so it got in the lungs, requiring the use of steroids and oxygen. And 4.5 milligrams of low-dose naltrexone was used over the course of a year. After 2 months, patient experienced significant fatigue, so a significant reduction in dyspnea, which is difficulty breathing. Follow-up CT showed significant reduction in liver and splenic lesions at 5 months. So, that's liver. Again, I can't read those, but the doctors can. Okay, psoriasis. This is kind of the new frontier, and I don't really have a good study here to show you on this, but I just wanted to show you, this is a patient before LDN, and this is a patient after LDN. So big difference in this person's life, going to the parties, going home, going out socially, and that. So, some people, and this patient was refractory to other therapies. Okay, I'm going to just hit these real quick because I want to leave time for questions. Opioid withdrawal. This is where I think, again, really fascinating, because at these different dosages, it seems to do different things. Here's a double-blind opioid detoxification trial of 127 opioid dependents undergoing a 6-day methadone taper. So methadone's used to taper people off narcotics. They gave low-dose naltrexone with it, and they showed that results elucidate neurobiological mechanisms of opioid withdrawal and support the utility of further controlled studies of very low dose naltrexone as a novel and effective treatment for the management of opioid withdrawal. In other words, they were able to help people withdraw off their medications faster and stay off of them. Here's one, ultra low dose naltrexone to improve opioid analgesia. I like this article because, again, it kind of goes through those G coupling proteins, explains how that works, which I would be happy to answer if somebody asked me on a question and answer. I'm not going to go through that because I think it's, just remember that a really tiny dose actually acts like a narcotic. But what happens is it affects the pain relieving, but it doesn't affect, it blocks some of the addiction. So, you know, one of the problems we have with narcotics, especially in, you know, as we now know, before COVID, it was the narcotics, right, that we were all talking about, all the addictions. Well, you know, what we know is that we have to keep giving people more because they develop tolerance and they develop cravings. So if we could block that cravings and that tolerance and that ability to have to give more, and if we could actually give less drug, so they don't, and that's what low dose naltrexone does because it's working on these different protein receptors to work. Depression, I think this one's interesting. Again, this one, they give a 1 milligram low dose naltrexone twice a day, so we don't just have to give it once a day in this case, and they showed substantial and rapid improvements in depression scores. Quality of life. This is a quality of life article. Summarized research regarding LDN roles as an adjunct therapy for patients facing the stress of chronic disease and chronic pain. Low-dose naltrexone presents a safe and promising approach to prevent and or treatment of many autoimmune, chronic pain, and neurological diseases that are often exacerbated by compromised immunity. LDN can promote positive emotional states and improve the overall quality of life for those facing chronic disease. So that's it. And, you know, I just did a smackling, okay, of the different articles on low-dose naltrexone. And I kind of concentrated pretty much on pain. And I threw a little psoriasis in there, and I threw a little bit on the depression, just to show you that we're looking at different things. But I also wanted to let you know that there's all those other conditions. And so the research is ongoing, which I'm always fascinated when things work by different mechanisms. So I love this kind of stuff because I really get into the pharmacology of it. So how do you know, what's your next step? Well, you know, obviously we're pharmacists and our expertise is in trying to find the right dose for you and making sure you understand how to use the medication and you get the therapy. But, you know, your doctor is the one that's going to drive your prescriptions, obviously. So if you have a doctor that's interested and wants information, I have binders of information that I could send to them. I'm happy to talk to them at any time. Obviously, if you want more information, you can contact us too. Our goal is to kind of work and kind of facilitate your therapy. We're certainly not going to get in and interfere, and not everybody may be a candidate for low-dose naltrexone. So, you know, our goal is to kind of work and help you with your therapies, okay? And with that, I went 45 minutes, and I know I talked very rapidly, a lot more rapidly than I like to talk, and I probably tripped over some of my words and said some things backwards. But if there's questions, Kylie, you can field them for me and ask them.
Okay. One. Wife has been using what she thought was low-dose naltrexone for CFS, but she was quartering her 50 milligram pills, creating a 12.5 milligram dose, which is obviously too high to work correctly. What is the best method to reduce the 50 milligram pills to the correct dose? Grind to powder, then how do you measure the powder?
Wow, that's a really tough one because unfortunately, what we do is we buy the straight up powder here and we make it, you know, in a capsulated form. So we can make that 1 microgram dose, which is, we actually have to do a couple of dilutions, which takes some time. We send our dilutions off and have them tested so that we know that our dilutions are right. Because if we don't have the right starting material, then, you know, we're not making the medication right. But when you're starting to get down under a quarter of a tablet, it's going to be really hard, you know, 12.5 milligrams. So I would probably, talk to your doctor. So you've already purchased the product probably. Um, I guess the question is the doctor going to keep you at a 12.5 milligram dose? I think that probably is a little bit, what we typically do is we start with lower doses at like 0.5 milligrams to 1 milligram. We like to start in that range, right, Paula?
Mm-hmm.
And we will slowly escalate it up somewhere in 2 to 4 weeks. We will increase that. Let's just, for example, say we started at 0.5 milligrams. Then in about 2 weeks, we'd go to 1 milligram. In 2 weeks, we might go to 1.5 milligrams. 2 weeks, we might go to 2. And there's different ways that people do things. But probably for chronic fatigue syndrome, we'll probably want somewhere between 4 to 8 milligrams. So even 12.5 milligrams seems a little high to me. It might work, and it might work for you, but most of our patients are down in that that 0.5 to probably 5 milligram dose. Okay. But I have people on 2.75 milligrams, 3.25 milligrams, 2.6 milligrams. I mean, we have patients all over the place. So the answer to your question is, the good news is low dose naltrexone isn't real expensive. A typical 90-day supply is somewhere from usually between $50 and $65, my thinking. Okay.
She kind of answered your question back. No, the doctor wants a low dose, but did not apparently know that naltrexone is available as a powder.
Yeah.
He also said, thank you for that information. So I
want to reach out and contact us, I can send information to that doctor to help them.
Yeah.
Yeah.
Absolutely. And I think that is all the questions as of right now. If there are any more questions and, if something comes up later on, feel free to reach out to us. Oh, maybe one more.
Good.
How familiar are you with the Sinclair method for curing alcoholics, 50 milligrams used in TSM?
Be honest with you, I'm not familiar with that. So they were using 50 milligrams of naltrexone for that. Is that what I understand? See if I can see the question.
Yes, 50 milligrams.
Well, that would be the dose that would be used for alcoholism. Yeah, because it's going to work as a blocker.
Yeah.
Right, and so that would be the FDA approved dose for that. And again, there's different ways they do it depending on what kind of dose they give you. The FDA will approve it like you could do 150 milligrams every 3 days. I think is one way they can do it. They have the injection product where you do the injection IM once a month. So, but I'm not sure what the Sinclair method is.
That might be something I'll write down that we can.
Yeah, we can look at, and I can make a comment on Facebook.
Yeah, absolutely. All right. I know we do have a lot of information on low dose naltrexone and alcoholism, or not low dose, but naltrexone in general, but says timing is important. That is TSM. Oh. Okay. Yeah, I'm not seeing any other questions currently.
Okay. Well, again, thank you guys for, I'll be on WOWO. I'll be on WOWO. We'll be covering a topic in the next mid-October. I think is the next time I'm on WOWO. And of course, we'll be talking in the next couple of weeks. So we invite you to that. thank you for spending your evening with us. And if you have any questions, feel free to reach out to Facebook, or if you want to call the store and talk to us directly, we're happy to send you or your physician any information. Thank you.
Yeah, most of them also received, well, they received the link through their email from my email. So if you have questions as well, another way to reach out would be just email me and I'll give them to Greg, and Greg can answer you later on. So.
All right.
Great. Thank you.
Thank you. Have a good night, everybody.
You too.
Bye-bye. Okay, so stop share, I guess. And
Whoops.
oops. If I end the meeting, you're going bye-bye.
What's it mean when it says like 10?